House Appropriations Subcommittee on Health and Human Services is called to order. Clerk, please take the roll.
Chair Morse.
Here.
Vice Chair Martis. Representative Hood. Representative Braybeck.
Here.
Representative O'Neill.
Present.
Representative Puri.
Here.
Representative Farhad. Representative Price.
Here.
Representative Skaggs. Representative Snyder.
Here.
Vice Chair Green.
Present.
Representative Bolin.
Here.
Representative Meerman. Representative Kuhn.
Here.
Representative Steele. Madam Chair, you have a quorum.
Thank you, Clerk. Welcome, everyone, to the Subcommittee on Health and Human Services. Today, we are going to take testimony from behavioral health stakeholders, specifically our Community Mental Health Association of Michigan, as well as organizations that work in community mental health. Obviously, behavioral health is one of the top issues that this state is trying to move forward, and so we're anxious to hear from them today to provide an update on the latest of the needs and what's happening for the CMHs. So I will welcome you all to come up. We have Alan Bolter, Associate Director, Community Mental Health Association of Michigan, Matt Maskert, CEO, Pathways Community Mental Health, Sarah Lurie, CEO, Clinton, Eaton, and Ingham Community Mental Health, and Brad Casemore, CEO of Southwest Michigan Behavioral Health. Welcome, thank you, and just make sure you hit the mic button before you speak.
Well, thank you, Madam Chair, members of the committee. Really appreciate the time of the committee to give to us this morning. So, and I'll be very brief. My name is Alan Bolter. I'm the Associate Director for the CMH Association of Michigan. Our association represents what's described as Michigan's public mental health system. So that includes the 46 community mental health agencies, the 10 prepaid inpatient health plans, and about 100 provider organizations that provide services, mental health, substance use disorder, and developmental and disability services for every community across the state. So today with me I have 3 of our members really from all parts of the state. So I think you'll get a pretty good perspective, rural, urban, from a CMH and a PHP perspective, that I'll have them introduce themselves as they speak and what communities they represent. But I think you're going to hear them touch on some of the challenges that they're facing. I think specifically they'll talk about workforce is a huge issue impacting our membership, administrative burdens. You're going to hear about the progress of our CCBHCs. And some of the material that I gave you, you do have in there an infographic on CCBHCs as far as a year 1 of the demonstration, some of the outcomes and results from the CCBHC program that's going on. So you have that in your packet. And then you're also going to hear them talk about Medicaid financing and rate challenges that are impacting our members. So again, you have a number of written material from myself on our association's budget, requests, key priorities, as well as some infographics. So with that, I will turn it over to Matt Maskert, who is the CEO of Pathways Community Mental Health Agency.
Good morning. As Alan said, my name is Matt Maskert. I'm CEO here at Pathways Community Mental Health. I'm going to be talking about the rural perspective of workforce shortage and administrative challenges. Pathways serves individuals with severe mental illness, severe emotional disturbances, as well as intellectual and developmental disabilities in the rural counties of Marquette, Alger, Luce, and Delta County. And for those of you that are kind of from Michiganders that use your hand to kind of show where you're from, Marquette is on Lake Superior. Delta is on Lake Michigan, which is fantastic, and Alger and Luce are to the east of us in the UP. So it's a long way from Marquette to here, but I'm happy to be here with you today. Not only do we have 4 rural counties, but Luce County is notably considered not just a rural county, but a frontier county due to its sparse population and considerable distances from urban centers with essential resources. Up north in the UP, the task of providing specialized mental health services becomes increasingly complex due to staff shortages and the distance between those population centers. According to the Health Resource Service Administration, all of Michigan's Upper Peninsula counties are designated as health shortage areas for mental health as well as primary care. Staff recruitment, it has been a persistent challenge for all Pathways County offices. In the last several years, the challenge has been intensified. Presently, 10% of our full-time employment positions are vacant, majority of those being clinical positions. The team serving children in Delta County, for example, has half the team missing, and one of the positions has been open for 650 days. We also have a position in our Delta County office that serves adults, and that position has been open for 878 days, or right around 2.5 years. And this isn't unique. This is not a unique problem to Pathways. The shortage of staff and the inability to maintain a waiting list for Medicaid recipients has led to increased caseloads for those team members that are still serving within the organization, resulting in burnout among the remaining staff. To address the staff shortage, we have sent staff from Pathways offices to those offices with the greatest need. This has resulted in weather-related vehicle accidents, as well as an exorbitant lost time for clinical care. Compounding the issue is the growth of the state budget allocated to the school-based mental health program. As of last year, roughly half of the work team at the Marquette Alger Intermediate School District were former Pathways employees. Additionally, social workers were leaving Pathways for employment for the Delta Schoolcraft Intermediate School District in Escanaba. These staff are attracted to higher compensation, less challenging clinical cases, and most of all, summers off. The exodus of professional clinical staff has resulted in significant loss of talent and expertise. In 2015, the average experience for the Pathways clinical team was right around 6.8 years. Presently, it has dwindled down to 3.8 years, a drop of 45%. For most frontline clinical staff, which excludes the clinical supervisors, the average experience is now less than a year, year and a half, 2 years in some cases. This makes serving individuals with serious issues very difficult for inexperienced staff. The hiring problem extends beyond master's and bachelor level clinical care and clinical professionals. The challenge is also severe in the direct care staff, most of whom only have a high school degree. Adult Learning Systems, which is the largest nonprofit specialized residential program in Central Upper Michigan, contracts with several of the community mental health providers, delivers personal care and community living supports for 24 hours a day for 125 individuals with developmental disabilities. Adult Learning Systems has an average of 270 direct care staff and experiences an attrition rate of 215 in fiscal year 2023. And that's not equally distributed between their homes. One of the rural communities in Dickinson County has 3 homes, and it has a staggering 221% attrition rate. Direct care workers receive an average hourly wage of about $16 an hour and frequently leave employment for easier jobs in retail, fast food, and other areas that are right around the same hourly wage. Adding to the challenge is the burden of extensive paperwork. Clinicians in the public mental health system face a significantly higher paperwork requirements compared to those in schools and private practices. Reports from the Community Mental Health Association indicate that paperwork and administrative duties could result up to about 30% of the clinician's workday. However, in conversations I've had with Pathways seasoned clinical directors, that could range up to at least 50% of their day of just doing paperwork. These demands not only limit the skilled practitioners have, but also how much time they can contribute to, it contributes to the driving clinicians away from the public mental health system and into other areas. Looking ahead into the next fiscal year and beyond, in my opinion, there's 3 points that we need to be considered. One is expansion. The investment in mental health services must take a comprehensive perspective, considering all funding from one additional funding for one system or solution may impact another. This is notable in the school systems. Additional money that goes into the school systems just pulls staff away from the severe the services for the severe within our system. Administrative burdens. This is an urgent need to reduce administrative burdens and allow an increased percentage of time spent caring for those we serve. It was a couple of years ago, one of my seasoned clinical professionals said, Matt, people don't get into the mental health field to be $100,000 a net and do paperwork. And that is absolutely true. When they're not able to do what they love to do and what they're driven to do and forced to do paperwork, they leave. And direct care workers, it is imperative that the wage adjustments for direct care workers increase. This will help retain and recruit caring staff to serve some of the most vulnerable Michiganders. So thank you for your attention to this important matter.
I think what we'll do here is we'll just hold questions till the end, because maybe one or two of you might be able to answer a particular question. So if the committee is okay with that, we'll go through all the presentations and then we'll take questions. Thank you.
Good morning. I'm Sarah Lurie, Chief Executive Officer of Community Mental Health Authority of Clinton, Eaton, and Ingham Counties, or CEI for short. We're located right here in the Lansing area. Thank you so much for the opportunity to speak with you this morning. I think you'll find some similarities in my comments and Matt's related to workforce. But it is with pride that I stand before you representing our organization as a certified community behavioral health clinic, or CCBHC. Our journey to achieving this certification as one of Michigan's original 13 demonstration sites has been marked by a dedicated effort and a very, very strong desire to more fully serve the needs of our community. This is a desire I know that is shared across the public behavioral health system. The federal CCBHC framework arose from the urgent need to address the escalating rates of suicides and the devastating impact of opioid epidemic across the United States. This model not only tackles those critical issues, but it also confronts various systemic challenges within the behavioral health care landscape that we've experienced also here in Michigan, such as accessibility, integration of evidence-based practices, care coordination and integration, and financial stability and sustainability. At our organization, we've successfully implemented a range of initiatives aligned with the core values and the requirements of CCBHC, including a Veterans System Navigator program, after-hours clinics, mobile crisis services, Consumer Advisory Council, care coordination projects, care pathways for health conditions, wellness coaching, same-day access, nurse care manager positions, and the Zero Suicide Framework. Expanded services have not only enabled us to respond swiftly to crises, such as the mobilization we were able to do following last year's tragic events at Michigan State University, but it's also positioned us as pioneers in the development of a crisis stabilization unit for our area. Moreover, our commitment to expanding services extends beyond crisis intervention to encompass outpatient substance use disorder services, medically assisted treatment, and support for individuals with mild to moderate conditions. By increasing access to behavioral health care in our area, we aim to alleviate the burden on emergency departments, jails, and reduce hospitalizations. In fiscal year '23 alone, we provided care to over 13,000 individuals and families, reflecting a substantial growth in our outreach efforts and the effectiveness of the CCBHC model. We did distribute our annual report, and in that is a page with some of the incredible data coming out of the CCBHC. Our data also mirrors the data that Alan shared regarding the rest of the Michigan sites. The CCBHC model truly allows us to be of greater service to the community by serving all with mild to severe mental health conditions regardless of insurance. We have felt so encouraged by the investment that Michigan has made in expanding the model during the demonstration project. And with continued expansion of CCBHC sites, we also ask for a corresponding increase in the non-Medicaid funds allocated to CCBHCs to maintain and expand service to individuals who are not on Medicaid who are accessing our services at CCBHCs. We'd also like to see ongoing investment and commitment to make CCBHC a permanent part of the state plan. During this time of tremendous transformation and opportunity, we have unfortunately also grappled with a shortage in the behavioral health workforce. We've had to be very creative in order to continue to expand services despite these workforce shortages. In the past 3 years, our workforce has turned over by 50%. With a strong focus on retention and recruitment, we are doing better and rebuilding, but we cannot afford to lose any more of our seasoned staff. To strengthen the hiring pipeline, we've greatly expanded our internship program. We are obviously very lucky to be in the same community as a large Big Ten university with a School of Social Work. And that has helped us in terms of being able to expand internships. It's also helped us by allowing us to start a program where we have funded our own cohort of 9 staff in completing their Masters of Social Work at Michigan State University. We appreciate efforts undertaken by MDHHS to look at tuition reimbursement, paid internship options, and loan forgiveness. This all helps. It really does. It helps us to attract and retain a good workforce, but it just can't seem to happen quickly enough. Why is retention so tough? Our work in the public behavioral health system is extremely rewarding, and as Matt discussed, it also brings heavy demands. Our clinical staff truly, they go into this field to help people and improve lives, but too much of their time is spent with paperwork requirements and meeting accountability demands placed on them in our system. Just last summer, CEI had a successful week-long national CARF accreditation review. That was followed almost immediately by 3 state-required audits and submission of 9 state-required reports. Audits result in cumbersome action plans, corrective action plans, and activities, even for small issues. We will repeat some of this again this summer. We are beginning the recertification process this month for CCBHC, and really pleased to see that MDHHS is allowing CARF accreditation to automatically meet some of the certification requirements. That is a step in the right direction. And the number of scope and audits could be reduced through allowing deemed status for CMHs with national accreditation such as CARF or joint commissions. The other factor driving people out are the uncoordinated, large-scale changes put forth to the system. We are actively preparing for several new initiatives for fiscal year '25 that require planning, training, and change management within our own workforce and with our provider network. For example, for fiscal year '25 this fall, we will begin using an electronic visit verification system for services provided in people's homes. We will begin using a new required screening and assessment tool called MichiCans for all children. This also impacts treatment planning. We'll be implementing a new tiered payment system for psychiatric hospital stays. And now, less than 2 weeks ago, we were presented with a plan for system redesign under conflict-free assessment and planning for fiscal year '25 that would fundamentally change almost every area of our organization, drastically impact our workforce and our delivery of care to those we serve. This particular change also threatens the success of the Michigan's rollout and the effectiveness of CCBHC efforts. Thoughtful consideration regarding the number of new initiatives rolled out each fiscal year is needed, with an eye to minimizing the disruption to the workforce and allowing us to maintain our focus on sound delivery of services. As we do our best to navigate through ongoing transformations and uncertainties, we remain steadfast in our commitment to serving the community and advocating for the continued expansion and sustainability of the CCBHC model. I want to extend to all of you an open invitation to please come visit us at CEI while you're in town, and come witness firsthand the impactful work being done to promote mental health and well-being in our community. Thank you very much for your attention and consideration.
Good morning, all. Madam Chair Morse and subcommittee members, thanks for permitting me to testify today. I'm Bradley Casemore, CEO of Southwest Michigan Behavioral Health, one of 10 of Michigan's regional prepaid inpatient health plans, serving over 290,000 of Michigan's most vulnerable citizens. Collectively, through our valued community mental health service providers and other providers, PIHPs proudly administer $4.2 billion in Medicaid, Healthy Michigan, federal block grant, and Public Act 2 funds annually. I'm here today to discuss troubling PIHP Medicaid financial estimates for fiscal years 2024 and 2025 that are troubling, particularly absent adequate Medicaid and Healthy Michigan rate setting and appropriations for fiscal year 25, a topic I know you are now deliberating and debating. Please know that the financial jeopardy is widespread, it's structural, and it is not a result of poor management. Please see today's Board Association testimony material for detailed information on the drivers of Medicaid revenue shortfalls and Medicaid expense increases. As Sarah said, valuable post-pandemic access, expansion, and quality initiatives statewide in youth services, certified community behavioral health, criminal diversion and justice services, opioid epidemic prevention and treatment, and multiple demonstrations place great strain upon the system for staffing, for administrative changes, and particularly in my testimony here today, proper funding of those new demonstrations where historical encounter and other cost data is not available. Just a quick background, for risk management, PIHPs are permitted to retain a portion of Medicaid and Healthy Michigan Plan revenue savings annually to go into the following year, and PIHPs are permitted to maintain an actuarial sound internal service fund also for risk management purposes. PIHPs are in a financial risk management sharing with the department, with the PIHPs taking early risk and then shared risk and then ultimately full risk to the department and the state. Please be reminded that PIHPs do not retain profits and that unused Medicaid funds revert back to the state. PIHPs and CMHs welcomed the recent fiscal year 2024 Medicaid rate increase of $116 million statewide, but we note that this is still $94 million less than the fiscal year 2024 appropriation. I want to share some specific projections for the system for fiscal year 24 and fiscal year 25. Please be aware that the facts and figures that I'm going to discuss now are under refinement and are subject to changes in the assumptions and facts and certainly rate setting from DHHS and Milliman and your own appropriations decisions. I'll also state that we do not have information on specific PIHPs today. Moving to the current fiscal year 2024, projections show 4 PIHPs with negative current year margins of $7 million, $15 million, $6.5 million, and $23 million. Also in 2024, another PIHP is at break even with no permissible savings going into fiscal year 25, and with other PIHPs using a majority or a large portion of their permissible Medicaid savings, also diminishing the resources for the following fiscal year. To restate another point, distribution of the remaining $94 million that's already been appropriated for fiscal year 24 would improve these circumstances. As it relates to fiscal year 2025, financial projections even worsen based on a number of assumptions of a system-wide increase in expenses of 3%, a 3% increase in Medicaid funds redirected to CCBHCs, a favorable thing, and revenues at fiscal year 2024 levels. With these basic assumptions, 5 PIHPs in fiscal year 25 will have negative margins of $14.5 million, $21.5 million, $11 million, $31 million, and $4.6 million. Then in fiscal year 25 with 3 other PIHPs at break even and 2 others with significantly reduced Medicaid savings. In fiscal year 25, absent material changes in rates for 24 and 25, 2 PIHPs are projected to enter into the risk corridor with the department, and 2 others will have depleted internal service funds. We all know this, but we will restate the PIHPs that we understand, and we will fulfill the fact that Medicaid services are entitlements and cannot and must not be reduced, suspended, or terminated when medically necessary. Part of the PIHP's responsibilities is to assure that that happens statewide. Actuarially sound capitation rates are intended to provide for all reasonable, appropriate, and attainable costs that are required under the terms of the PIHP DHHS agreement for the time period and the eligible populations. To restate what others have said, revenue decreases stem in large part from a cessation of federal public health emergency Medicaid infusions of funds that you're familiar with, the lapse of federal economic stimulus packages post-pandemic and post-public health emergency, as well as critically the requirement for Medicaid and Healthy Michigan Plan redetermination that were suspended during the public health emergency and reinstituted last spring about a year ago. The revenue decreases from those redeterminations and losses of individuals for Medicaid eligibility and Healthy Michigan eligibility have materially and significantly reduced Medicaid into the state, thus to the PIHPs, thus to the CMHSPs. Our message to you today and to the rest of the legislature is to support and appropriate fiscal year 2025 Medicaid, Healthy Michigan, Certified Community Behavioral Health Clinic, Medicaid and non-Medicaid funds, and, as Sarah mentioned, mental health general funds necessary to protect the Medicaid and non-Medicaid community behavioral health service recipients and to insulate public behavioral health system clientele and ultimately the state probably from a jarring financial blow in late 25 and early 2026. MDHHS and the state's actuary Milliman are aware of these facts and are making best efforts to project, to plan, and to perform. In closing, I would also like to turn to the topic of opioid settlement dollars. You are all aware that Michigan, over the next roughly 15 years, will receive roughly $1.5 billion with a B, partially through the state and partially through municipalities. Those funds have specific permitted uses, as you know, under the opioid settlements, and yet those permitted uses are quite broad and wide and create lots of opportunity for effective and efficient implementation of both the state funds and the municipal funds. I want to either remind you or inform you for the fact that the PIHPs are all 10 of us state-designated community mental health entities. State-designated community mental health entities, sort of a misnomer, but under the mental health code in multiple sections, which I've provided to the committee, The community mental health entities are the only statewide regional body with statutory roles and authorities in substance use prevention and treatment, policy, planning, programs, and proofs of performance. The CMHEs have over 10 years of data, encounter data, epidemiological material, and have mature communication channels into every community in the entire state. So I bring this to your attention or reinforce it with the specific suggestion that the legislature and this committee consider the community mental health entities as named administrative vehicles for state and/or municipal opioid settlement funds as you deliberate effective and efficient deployment of those funds. I am particularly interested and enthusiastic about this as a current member of the State Opioids Task Force, an appointee of the governor, as well as a just recently termed out member of the Opioid Advisory Commission created under PA 84 of 2022. And with that, I'll close my comments. Thank you.
Thank you all for being here today and for the incredibly difficult work that you do managing all of this. There's a few subjects I want to sort of kick off the questions with just to help guide this conversation since we have a fair bit of time for questions and discussion. The first one I would like you to break down and simplify is the request around the conflict-free access and planning and the significant change that the department has proposed with how that works. We did all get a sheet here from the CMH Association, so you can look at that. But if one of you could just, as simply as possible, break down the problem and how you think it should be addressed.
I'm afraid I don't have a way to simplify it. I'm not even sure where to start with it. But in our system, and particularly as a CCBHC, there is a high value in being able to bring somebody into care seamlessly, get them connected with services. So that is how all of our systems are built in our organization. We try to get people in from, whether it's through crisis or through our access department, into same-day intake access. We have same-day services, into treatment planning and into services just as quickly as possible and as seamlessly as possible. This plan that's been proposed would not allow the same organization to do the intake assessment and treatment planning for an individual and provide the treatment service. So that means we would have to split apart every clinical area of our organization, and we would not be able to do both services. How we would resolve that, I can't tell you today, but it will be very disruptive. It will drive many of our staff out the door, into schools, into private practices. It will be quite devastating. It also is not in line with CCBHC requirements, and it would be a very huge, heavy lift to even attempt to do for fiscal year '25. But even if we could, it's not a good thing for the system or the folks we care for. And in my understanding, not really required in a system that is public, where we're really governmental entities and not trying to make a profit off of referring people to ourselves for both functions. And I'll stop there.
I'd just like to jump in real quick. From what we are seeing and we're hearing from those we serve is that their concern is having to tell their story, their life story, to multiple people. So you're telling your story to those that are providing the intake and the treatment planning. Now you're telling your story again to those that are serving. That's not person-centered. It's not what they want. And the listening sessions that the department has done and the feedback that we've gotten from at Pathways from our Recipient Rights Advisory Committee is this is something that is not beneficial for those that are in our care.
Speaking for the PIHPs, I can say that we have been informed that the PIHPs, that we will be required to submit roughly by May 15th, a conflict-free access and planning transition or implementation plan. And yet I can also speak for the 10 of us, we do not have the specifications adequately enough in detail to be able to do that. And also the 10 of us and many of the CMHSPs, if this comes to fruition, have serious considerations concerned about the disruption to business practices and processes, to electronic health records, electronic medical records, data exchange, and managed care information systems in order to get this anywhere near to the stated October 1, 2024 due date.
Well, I'll just add, because I did get a breakdown from someone in the system. And so just for the members of this committee to understand, this is a proposal that's regarding trying to avoid conflicts of interest in the community in the community mental health space, right? So the department has set forth some new rules that they think will avoid these conflicts of interest, but the rules, or the new rules as proposed, cause issues for the CMHs and the PIHPs. And the argument, as I understand it, is that the rules can be met by just setting up firewalls in the CMHs to ensure that there are not conflicts of interest, because it's about, you know, the organizations making money off of treatment planning essentially, which is not, these are nonprofits, so that's not what they're doing. But, you know, we have to get some more information from the department as to, you know, the reasoning for it, and if there's some solution that we can make work for everyone to accomplish their goal of having no conflicts of interest in the system, while making sure we're not making additional headaches for the system itself. Rep Braybeck has a question, so she can go ahead. She's joining us virtually.
Thank you, Chair. I appreciate it. And actually, your question was one I was wondering what's been articulated to the CMHs and the PIHPs about what problem we're trying to solve. So I appreciate that. But what strikes me is that I think it's, you know, great to be aware of, you know, conflicts of interest. That's fine. But clinically, what strikes me is that, you know, as providers, folks seamlessly all the time do treatment planning and then the provision of that treatment. And so it's, I feel like it would be very helpful to hear more from the department on what the specific issues are that they're seeing that they believe necessitates this, because to me, as I see it right now, it does put another burden. It doesn't make clinical sense to me. And so that additional information would be very helpful.
Thanks, Rep Braybeck. Rep Boland.
Yeah, thank you.
Thank you, Madam Chair, and thank you so much for being here and for your very important work in your role in our community to help so many with a really growing need. I find this very troubling, that it seems to me the intake person, you start to build a lot of trust and a relationship. And while I understand and can appreciate the requirement for transparency and disclosure, I just don't think what's being proposed is the right path. So do you have a suggestion on, you know, how we might meet that requirement without totally disrupting? One, we have a model that does seem to be working. And could it be done, you know, by putting other guardrails on the programs, audits?
Certainly, I believe so, and I believe that Community Mental Health Association has submitted a list of recommendations of other ways to approach it. And I do want to note that this is not a new requirement, the conflict-free. It's something that we have met within the system until this point. So some of the things that we have done in the past that we still do is we do have a different person in our organization who does the intake and another person that authorizes the services and sends it on for treatment. So there is some different eyes on different parts of it, but we're able to do that seamlessly through the workflow in our organization. It's not easy, would not be easy to replicate that, sending somebody to two different places. So that's one area. We also have additional staff, quality, customer service, recipient rights, another staff that does reviews, utilization management, and another set of eyes looking out for any of those conflicts of interest as well. We do also have a provider network, so there's choice for many of the services that we provide. So if people do not want to be seen by us, or if they even want somebody else to facilitate the treatment planning, the person-centered plan, they can use an outside facilitator, an outside organization. So we've tried to build in a lot of options for people to exercise to avoid that conflict.
May I ask a follow-up to that? So is there anyone through this kind of continuum of care and you're treating somebody, and is there anybody that's monitoring to see like, okay, yes, this person can move on, they've moved through their treatment plan, because there's a waiting list, right? There's a greater demand for services. Is there somebody making sure we're not just keeping people here and not getting the care for people here?
Yes, that would be a function of some of our utilization managers, but we also, within our clinical areas, the supervisory level, the coordinator level, are reviewing cases. They're the ones authorizing services, so that they are another set of eyes. So it goes from the therapist, maybe who's providing the care, the coordinator who has access is looking and authorizing those services, and then our utilization management.
Rep. Price?
Thank you. I'd love to hear more about the need for your providers to do so much paperwork. If you can compare a little bit the need that you see your providers doing compared to somebody who's perhaps providing some similar services in the public space. I hear you say one of your proposed solutions is to carve out exceptions for national accreditations, for instance. I would love to hear any more proposed solutions and ways specifically we can help address this problem, which I think we all agree would also help with the workforce demands and retention, keeping folks in the job for the reasons they got involved. Thank you.
The clinical paperwork that's demanded of the staff can range up to 10, 12, 14 pages long for a plan, similar for an assessment. It really is large and overbearing on some of that. It's just been a process of, well, this audit, we would like to see this data, this audit, we would like to see this piece of information. And that's gone on over time, to the point where we've got a real bloat to some of the clinical documentation. On top of that, now we're talking about training and making sure that the clinical staff are completing this documentation appropriately. And it makes it very demanding, and the complexity level goes up quite a bit. To compare and contrast over at the school systems and private practice, it's some billing information and a short document, as I understand it, within those two areas.
And I guess, specifically on the deemed status issue, as Sarah mentioned, she goes through the CARF process where they come in and they look at a whole host of financial data, they look at different programming and things like that, but then turn around, then the state comes in, looks at that, and that typically falls down to the PIHPs to come and look at that as well. We had a report that we did several years ago that I think our members spend several thousand hours a year doing these continuous reports and audits and things of that nature. And on the workforce side, I mean, I always describe it as the two Ps. There's pay and there's paperwork. And if we can't increase the pay, then if we decrease the paperwork, that certainly helps. So, I mean, and we have a long list of other administrative items I'm more than happy to distribute to committee members and get that to you. So thank you.
Okay, next, I'm just going to broach the subject of the opioid dollars. So we do know that Michigan has a quite healthy balance on the books. I've seen the spending plan. I think maybe what, members of the committee may or may not understand is normally PIHPs handle the substance use patients that Michigan supports. And so I guess my first question, first of all, clarifying too, we cannot dictate what the municipalities do with the dollars. That goes through the AG. We have no authority over that. So we can dictate the state dollars. I sincerely hope that over time that there is some sort of developed system where we at least collaborate on what the spends are, because I think a lot of the municipalities are struggling really on how to spend the dollars. So I certainly hope that we can continue to build the system and make sure that we're using those dollars wisely and really getting to the people who need the help and making a huge impact. $1.5 billion. I mean, we can't let that slip through our fingers. So I guess my first question is, I've seen the spending plan. I'm assuming some of it goes through your organizations, or can you speak to whether some of it funnels through PIHPs, or is it all going directly to organizations that maybe you already contract with?
Sure. I'm going to take this one first. I've been deep into this with the Opioid Advisory Commission, the Opioids Task Force, and working closely with the Michigan Association of Counties, who very wisely put in place for their membership a full-time technical assistance advisor who's very talented. So, yes, there are state funds and municipal funds. Yes, we all recognize that municipalities are direct recipients as participants in the opioid settlements, that they too have to adhere to and abide by the so-called Exhibit E or similar requirements. We understand that those funds are administered through the Attorney General's office. So therefore, yes, focusing on the funds that come to the state through the Opioid Health or Healing and Recovery Fund, which the legislature created simultaneously with the Opioid Advisory Commission. Yes, the department has the clearest role and responsibility at this point for distribution of those funds, the state opioid settlement funds. I will say, I hear the department get bashed a lot on this topic. Having been involved with it for 2 years, I'm satisfied, even impressed with what the department's taken on. They did this department did statewide needs assessments before the money even came rolling in. They did a lot of spade work. They did a lot of organization. The Opioids Task Force, chaired by Dr. Bagdasarian, was reconstituted about 6 months ago, specifically with public officials from each of the 10 PIHP regions to sort of continue to meld that. I do have confidence and optimism that the Opioids Task Force and the Executive Branch and the Opioid Advisory Commission in the Legislative Branch will continue and will be urged to meld and leverage and synergize what they're doing. I'll repeat my suggestion again that the CMHEs, the community mental health entities, i.e. the PIHPs, are the only statewide regional entity with statutory roles and authorities, and we've been doing this for 10 years, most of us doing it for more than that, it being substance use disorder prevention and treatment, grant administration planning. We all have multiple community advisory groups. We actually all of us have what's known as a substance use disorder oversight policy board. That board controls the Public Act 2 funds and is appointed by county commissioners. So if I had to make a specific or just thought that popped into my head is that the legislature could consider naming specifically the CMHEs in a line appropriation or in boilerplate as a go-to place for which state funds, and could also encourage, not require, could encourage municipalities, including with planning grant funds, because communities have limited resources as well, to work with their CMHEs who already have all the data I just spoke of, the unparalleled subject matter expertise. And I'll also point out, all the PIHPs, CMHEs just submitted to the department, and I dare to say they've all been approved by DHHS, 3-year strategic plans for their regions for substance use disorder prevention and treatment. So sort of my frustration in general, not with bodies or with people, is there are a lot of things that are low-hanging fruit that are already in place, that are already proven, that can be readily be scaled, replicated, spread across the state, and there are also a list of many, many, many common consensus recommendations that can be chosen, selected. The question in any public democracy is who gets to make those choices and decisions? And as the legislature, elected by the citizens of the entire state, sort of that falls upon you, and so I guess that's my observations.
Rep. O'Neill has a question.
Yes, thank you, Madam Chair, and thank you for your dissertation on the structure as we know it. Let's see if I can say this right. You know, we really have to, I think, drill down a little further because, you know, we have these scenarios where we have resources available for a number of, or myriad of things. And then at the end of the day or the term of the distribution process, we find, or I've found, that a lot of those organizations that really impact and touch the people, they don't get the money. Okay? So, you know, we really got close eyes on this. I know I do, and other of our colleagues do. We just recently held a town hall with community stakeholders in Saginaw County, talking about the needs and also having those stakeholders there to understand the fact that, as you said, it's the legislator's role to make sure those funds are dispersed properly. And so we want to make sure that happens. Saginaw County, 97th percentile in terms of need. And I shared with the opioid liaison that came to Saginaw initially before we had the session that this is not just an information grab, if you will, lack of a better term, in terms of the disenfranchisement that has occurred in communities across the country, particularly urban communities, where you get the data from that community, you take it, utilize it to get the resources, and the folks that gave you the data that need the services are left out. Okay, so I don't want to have that violin music played again over with this episode. I know the counties have their money, the cities have their money, but the state has our pot. And so I just want to say to my colleagues collectively, let's make sure we consider, working in a unison form. And I know our chair shares the sentiment. It's also the Senate chair as well. So it's going to be a systematic approach collectively to work to make sure these resources get to where they need to go. So thank you, Madam Chair.
Rep. Steele.
Thank you, Madam Chair. My question is really has to do with the redetermination and that there has been a cut of the number of people that have been covered in this program, and the price should reflect that of basically how you offer services. And I just wanted to see if this has maybe helped put the prices back into line and the number of staff and that type of thing. So I just wanted some background on how this is going to affect you with these less people in the system.
Let me take a stab at it, and I know the Board Association has materials as well. So for the Medicaid PIHPs, we administer Medicaid and Healthy Michigan for all the specialty populations, right? So severe mental illness, serious emotional disturbance, intellectual and developmental disabilities, autism spectrum disorders, and substance use disorders. By nature, those are chronic, lifelong disorders, maladies, that persons who are in the care of the specialty supports and services programs, sometimes they're episodic in and out, but by and large, most of them are with us. The 290,000 folks, give or take, many of them are with us for a lifetime or decades, particularly now that, particularly with our intellectual and developmental disabilities population, as their parents age out and become frail, who had been their primary caretakers. So that's the first point to make, is that the folks who are in specialty supports and services are not the mild mod, are not the unserved because they don't have need or demand. So what happens is our patient population, our service types, amounts, scopes, and durations remain the same. Therefore, our expenses remain the same, more or less. In fact, they go up with demonstrations, Medicaid demonstrations, outreach, reduced stigma around mental health and substance use disorders. And yet the pool, because the PIHPs and then the CMHs are cost settled with capitation, the pool that we have is, I'm going to use a number here, instead of 100 million, it's 93 million, because a number of people no longer qualify for Medicaid. They no longer are, the state is no longer paid a capitation for them, therefore we're not paid a capitation for them. And I probably got too technical, so let me throw it over to Sarah and Alan and others. But that's sort of the gist of it for the PIHPs in simple terms.
Our demand doesn't go down when Medicaid enrollment goes down. It stays the same, and it puts more of a burden on our general fund to keep people in care, so.
Yeah, and I guess I would say, the number of people that were on Medicaid during the pandemic, I mean, it grew to over 3 million people for the first time ever. The amount of people that are dropping off now, that drop is much deeper and steeper than I think we thought it would be and what I think the department anticipated it being. So the number of people that are dropping off means less revenue that are coming in. Our members, touch 300,000 or so people. They really rely on their community-based partners to do this redetermination process to make sure people sign up, re-sign up for Medicaid, and the number of people that are dropping off has had a dramatic impact on the overall revenue. And I think the other key point when we talk about the redetermination process is there's various Medicaid buckets, and they get reimbursed at a different level depending on what Medicaid bucket someone gets put in. So if someone is considered disabled, aged, or blind, they get roughly $400 per person per month. But if it's someone that is Healthy Michigan, so Medicaid expansion, they get roughly $40 for that person per month. So making sure someone is appropriately categorized as they go through that redetermination process is extremely important as well. When Michigan first implemented Healthy Michigan, we saw back in 2016, 2017, like 40,000 people going through redetermination on an annual basis get shifted from disabled, aged, and blind Medicaid to Medicaid expansion. That represented roughly $100 million overall financial hit to our members across the state, just because of the difference in the financial reimbursement. That's what we are, particularly keeping an eye on this time around to make sure that everyone that gets redetermined gets put back on Medicaid is absolutely critical, but that they get put in the correct bucket. Now, they can, after the course of the year, shift people back around and make sure they get appropriately slotted, but that takes quite a bit of time and effort as well. So I think it's the number on the front end is key, but also what bucket they get put in is just as important as the total number as well.
Rep. Braybeck.
Thank you, Chair. Thank you all so much again for being here. When you were talking about this issue, two things came to mind. One, and I connect this with the administrative burden. When that DAB funding, the deaf, age, and blind category, there was redetermination around there. Again, that's not going to change from year to year. When someone is, it's determined that that's the kind of silo that they should be in. So that I remember when that redetermination happened, and it didn't make much sense to me. And it also increased then the administrative burden, because I know locally that meant that our CMHs, PIHPs really had to, as our local CMH person talked about this process, really bird dog to make sure that, if folks were DAB recipient one year, that they, again, through that redetermination process, continued in that with that designation. So I just, when those kinds of things happen, it is challenging, I believe, for the systems because of the increased administrative burden, but the loss of potential resources for our constituents. The other issue I'm wondering if you could speak to is, and yes, the number of folks that you have to serve does not change. I mean, in my mind, besides, like it stays fairly flat. And that's separate from the number of folks who are redetermined in. But what I do think can impact this is, and I can't remember who talked about this before, I'm sorry, but CMHs and PIHPs are not able to retain any savings. Is there anything at the federal level that stops us from being able to allow CMHs and PHIPs from doing that?
Hi, Rep.
Retaining those savings.
Hi, Rep. Brayback, Brad here. Glad to have you here.
Hi, Brad.
Up in the ceiling somewhere. Let me say that I might have misspoke, so let me clarify. PIHPs for the Medicaid and Healthy Michigan program are permitted to keep a portion of savings from a current year to go into the next fiscal year.
For the risk corridor?
For use in the following year. In addition, PIHPs are permitted to develop and maintain an actuarially sound internal service fund, which also is intended.
Yes.
That is the primary purpose for the internal service fund is future risk management. The ISF basically cannot be touched unless the entirety of the region or single CMH, as the case may be, is upside down, so to speak.
Okay, I understand. And those funds are capped, right? At a certain percentage?
Oh, yes.
Am I
There are
misremembering?
specific specifications for both the Medicaid savings and for the internal service fund.
Yeah, okay. All right, that's helpful. And so is it fair to say that beyond those caps, that money could then be utilized to help with some of these issues that you're talking about, if you were able to retain beyond that cap?
Yes, if it were in the state federal documents and if it were in the PHP contracts and if.
Yeah, right, I understand. Yeah, okay. Thank you.
Rep. Bolin?
Thank you very much. I have a question for you, Sarah. You made reference to your visit verification system that you're implementing. Can you expand on that a little bit?
It is a requirement for particular services. One of our biggest services being community living supports in people's homes. And so it will require an electronic check-in and check-out by staff.
Okay, so I think it's great that we're able to go to people where they're at, and we see it in some of the maternal health stuff too. Like, do you think that shows, that's worth the investment in being more people respond to services by going into their home?
I think that we are already providing those services. This is, I think, just another measure of accountability under Medicaid to make sure that there's a verification of somebody's visit. So in terms of keeping the integrity of the service and validating it, it makes sense, but it affects one of our hardest to retain positions, and that's what we call our techs, our residential techs, and so many of those folks aren't quite as technology minded. So it's still a heavy lift to get people up and running on a new system like that.
Well, that concludes the questions and comments, so thank you all for being here. Again, thank you for your work on behalf of the people of the state of Michigan. We very much appreciate it and your time today. Rep. Price moves to excuse absent members. Hearing no objection, absent members are excused. And seeing no further business, this meeting is adjourned.